Well, dear all, welcome again for yet another ground round. هذا تسجيل عن المحاضرة اللي قدمناها أمس مع the group Endocrine Society in Iraq. I'm trying to catch up with all my presentation that I have missed out on and did not record on YouTube. Because of the internet, interrupted internet connection during the lecture, it's very hard for us to record the lecture live. هذه المشكلة. I have to record it after the presentation. Anyway, tonight's or this month's round will be addressing hyperthyroidism during pregnancy. I will be discussing etiologies, presenting some case vignettes, with a particular focus in management of Graves in pregnancy. We'll discuss some of the diagnostic dilemmas during pregnancy, postpartum thyroid disorders, and also fetal and neonatal thyroid dysfunction. So to classify the etiologies, I found it easier to look at it in these under these categories. This is how I categorize it. شوف حالة يعني hyperthyroid. The first thing I ask myself, is it related to TSH receptors? Is it related to inflammation of the thyroid, thyroiditis, and or is it related to nodules, or related to surreptitious intake of thyroxine? Now, فيما يخص the causes related to TSH receptor overstimulation during pregnancy, so the commonest one, of course, is Graves' disease. Well, actually, the second commonest one in pregnancy is Graves' disease. The commonest one is gestational hyperthyroidism related to HCG. There are any other condition that would lead to HCG overstimulation, such as trophoblastic disease, and of course there are the rare causes of TSH producing pituitary adenoma, which we don't tend to pick up. It's uncommon, but we don't tend to pick it up during pregnancy. A condition of familial gestational hyperthyroidism related to TSH receptor mutations. Again, these two conditions, whether it's gestational or familial gestational, they need no treatment. The other category is thyroiditis, such as viral or Hashimoto, bacterial, fairly uncommon in pregnancy. لأن البريجنسي مثل ما تعرفون حالة of immune modulation. The other causes is multinodular or solitary toxic thyroid adenomas. Now, generally speaking, uncommon in the young population, but it still can happen, and we still can see it. I didn't put any slide الحقيقة بهالمحاضرة عن toxic thyroid adenoma لأن I want to simplify the presentation and focus on the two commonest causes, which is اللي هي gestational hyperthyroid and Graves. لكن عموما بالsolitary toxic adenoma, you tend to have predominantly T3 thyrotoxicosis without hyperemesis gravidarum. You can get T3 hyperthyroidism in gestational thyroid disease, but they tend to be associated exquisitely with or distinctly with the hyperemesis. When make عندك hyperemesis, raise T3, trap TSH receptor negative, then you could think of doing an ultrasound and make sure there is no nodules there. I have seen one case. In a lady in her 20s, pregnant. She probably had the toxic thyroid adenoma prior to pregnancy, but it wasn't diagnosed. And then we ended up doing a hemithyroidectomy during the second trimester. Moving along from that point to another causes of hyperthyroidism. Over-treatment with thyroid hormone, that's easy. That's the easiest to treat. You just cut down on the thyroxine dose. Factitious intake of thyroid hormone, that's actually common. This is not rare. هذا شيء يعني حقيقة وارد كثير لأنه كثير من females with RMS reproductive metabolic syndrome they go for health products help them to lose weight. These health products will have thyroid extract, and sometimes they do take thyroid hormone لأن يقرون بالجوجل إنه يساعدهم على تخفيض الوزن، وبالتالي they can resume their periods because they want to get pregnant as soon as possible. So they get pregnant through they lose weight لأنه they hyperthyroid. They resume their periods, albeit irregularly. They get pregnant, and then you end up with a hyperthyroid pregnant females. We usually in the non-pregnant females tend to pick up this when we look at the thyroglobulin. لأن تعرفون حضراتكم the females, the patient will not volunteer these information to you, so we rely on the reduced level of thyroglobulin. ولكن المشكلة إن thyroglobulin level tend to go up in pregnancy, so it's going to be very difficult to interpret the result unless and until the patient tell you يعني بوضوح بهالخصوص هذا. Now practice points is first trimester. في عادة الآن كل المختبرات الرئيسية لازم عندها trimester specific TSH reference range، ولكن إذا ما كان هذا موجود فللسهولة، وهذه الحقيقة هي rough range ولكنه validated reasonably reliable. In the first trimester TSH you need it to be less than a minimum of 0.1 in the first trimester, minimum lower bound of normal reference range هو 0.2, and بالsecond trimester, with third trimester is 0.3 up to 4. Okay. Now T4 and T3 levels that depend on the local population studies. These ranges are poorly validated. ولكن احنا عموما we rely on the if we were to treat with someone with underactive thyroid, for example, we aim at a lower TSH and high normal T4. Okay, we don't look into the T3 levels. بالعكس إذا كان عندك مريض عنده T4 ولا يعني hyperthyroidism, when you treat with anti-thyroid drugs, you like the T4 to be on the right upper margin of the normal reference range for a reason I will discuss later on. Now please do remember that low TSH can be present in about 10% of your pregnant females. So احنا كان هناك poll بالمحاضرة إنه would you consider gestational hyperthyroidism based on low TSH, and the answer is no. لأنه 1 in 10 females can have a lowish TSH, mildly reduced as a normal variation. Now 1% of the pregnancy female من كل 100 امرأة حامل هناك تقريبا 1% أو 5 بالألف راح يكون عندهم ال TSH normally suppressed. Okay, so you need to expect, usually because of TSH receptor mutations. Now وهاي تكلمنا عنها في محاضرات سابقة subclinical thyroid اللي يحب يرجع لها. Now the FT3 is very unlikely to be increased, but it can go without hyperemesis لأنه it's a state of calorie deprivation, and the beta HCG من الأسئلة اللي خليناها بالبول هو increasing beta HCG is an adaptive physiology trying to promote more and more FT4 and FT3 to face the relative calorie deprivation the females get into during pregnancy because they're carrying another human they need to feed. And this will lead us to tonight's topic of gestational hyperthyroidism. This is a slide that demonstrates, it sounds a bit complex, but it's actually very simplistic, and we all should know it from our basic, our physiological, our basic science knowledge, that the HCG shows a homology to the TSH receptor, to the TSH molecules, and therefore it can stimulate the TSH receptors. The stimulation is related to the level of HCG. Now, it is important to appreciate، هذا مهم جدا من فضلكم، إنه احنا لازم نعرف إنه ال gestational hyperthyroidism they tend to be clinically thyroid. Usually, but not always, they could have hyperemesis. It does require no treatment. It settles by 20 weeks, but it settles down حقيقة قبل 20 weeks. Okay, when the HCG levels start to drop down, the TSH levels start to normalize. Okay, so when you have these mild cases, هذه الكيس اللي قدمتها لحضراتكم كانت classical, and you could see that the يعني إنه الكيس كانت asymptomatic و very mild hyperthyroidism. You don't need to treat. Mild hyperthyroidism is harmless. يعني إذا تخلي هذا الشيء في بالك ما تسبب مشاكل كثيرة على الإطلاق. Then you will approach these cases with less anxiety. You'll be more, you approach it in a more confident and relaxed way. We compare the beta HCG to the TSH. The relationship with the HCG and T4 is not very impressive. So in the first trimester, the T4 tend to parallel the HCG level. It goes up together. ولكن the second trimester, this linear relationship is lost. So you could see the dots of distribution here is cylindrical, almost cylindrical shape. Well, it's getting spherical. تصبح دائرية بالsecond trimester because of loss of linearity between the two hormones. Now, and that's why we really don't look into the FT4s when it comes to the HCG or gestational hyperthyroidism assessment. بالإضافة أن ال FT4 level of range is poorly validated in pregnancy. Now, the TSH is a different story. It has a good, more or less linear relationship with beta HCG. Both in the first and in the second trimester, you could see that the relationship is still more or less cylindrical. And we need that. Beyond the second trimester, the HCG level should really have dropped down significantly, and the whole thing is over. Now, how to differentiate between gestational hyperthyroid and grave disease? Now, usually there's no prior thyroid symptoms, and if anything, the patient is not symptomatic. They could have hyperemesis, but this is not a prerequisite. They can have goiter, but no thyroid eye disease, or no eye symptoms, no eye signs that suggestive of thyroid disease. There will be a mild drop, but not usually a drop in the TSH, but no suppression. You can still get some cases of suppressed TSH. The FT4 can be high normal or just slightly elevated. The FT3 can be either normal or just slightly elevated. Now, the beta HCG مثل ما قلنا لحضراتكم is very high. And it usually happens in the first trimester, and it dissipates by the second trimester. So it's a transient وماكو prior symptoms. Okay. وإذا المريض كان عنده prior TSH normal level, then you have got the diagnosis. The ultrasound of no value in this condition, and you don't need to do any nuclear imaging. The grave disease, on the other hand, they tend to have symptoms prior to pregnancy. لا تسأل المريضة تقولها كان عندك يعني palpitations and unintentional weight loss وما إلى ذلك. The answer can be easily yes. They can have thyroid eye disease. The vast majority of Graves' disease will have some degree of thyroid eye disease. Some of them are specific for Graves and some of them are not. Again, they can be goitrous like any other overactive thyroid. The antibodies, both for TRAb and TPO, can be positive. Now, please do remember there are still cases of Graves' disease with TSH receptor negative or mildly positive. If you're in doubt and you have very high TRAb, more than 3 upper normal limit, then you have got the diagnosis. You can rely. مرة أخرى هذا أحد الأسئلة اللي انسألت إنه هل بالإمكان الاعتماد على التراب positive في diagnostic Graves, and the answer is yes if you have more than 2 to 3 folds in upper limit of normal levels of TRAb. يعني كان TRAb عندك مرتفعة بشكل ملحوظ جدا, you have got the diagnosis. You do not need to question it. ولكن هناك بعض الحالات مثلا عندنا upper normal هو less normally TRAb levels under 1.8. فإذا كانت 2 and 2.4, this marginal variation can represent a lab error, assay dilutional يعني assay error. ولكن احنا بنكون يعني 5, well 6, 7, 10, 20 إلى آخره. This is very positive. The TSH can be very low or even suppressed. The FT3 can be very raised. The FT4 again can be raised. The beta HCG in the lower than the 97th percentile, فمو كلش مرتفع, وبالتالي ratio less than 200,000. It is persistent. It starts before pregnancy and continues thereafter. Now, if you are in doubt, and there are cases that you're really not sure if it's gestational hyperthyroid or Graves' disease, and it's only mild hyperthyroid, you can observe mild hyperthyroidism is not harmful particularly. So we could just wait and see until we get the diagnosis. As we go along, you see the HCG going up, or the symptoms of hyperemesis develop, or the whole condition settles after 10-12 weeks, then you're safe. Now we'll move along to the second case vignette of a 34-year-old lady known to have Graves' disease for about 6 months, currently on 50 milligram carbimazole. She's clinically athyroid. She had a low TSH with normal T4, T3. Her TRAb levels has dropped down from a baseline of 8.2 down to 4. No upper normal is less than 1.8. Now she came here planning to get pregnant. She's 34, and what's the advice she would like to give? So what are your treatment options? So we have to take the patient through the risk of Graves' disease in pregnancy. That's what we need to counsel her about. There is the maternal risk, which composed of miscarriage, or preeclampsia, preterm labor, of course, and possible thyroid storm. We have seen cases of thyroid storm either during pregnancy or during cesarean section, when they develop tachycardia, hypotension, and they need a lot of IV blockers and steroids. And there's a condition of heart failure even outside the thyroid storm, so they can develop CCF during pregnancy because of poorly controlled Graves' disease. The fetal side of the complication, we tend to get it when the TRAb levels 3 times upper limit normal, and some authorities suggest 5 times upper limit normal. So the fetus can develop hyperthyroidism, intrauterine growth retardation from overtreatment, or even from hyperthyroidism itself, prematurity and hydrops fetalis, and there's of course a risk of stillbirth that is not insignificant. And please do not forget that the neonatal post-delivery, the newly born child can develop hyperthyroidism. So when we approach the cases of Graves' disease during pregnancy, there are 3 parties involved in the management: the patient, the endocrinologist, and the obstetrician. Now, the patient priority: symptoms control, medication, side effects, fertility if she's planning to get pregnant مثل الحالة اللي عندنا, when the fetus well-being. The endocrinologist's priority is to identify the etiology. Is it Graves? Is it gestational hyper, and so forth من الأسباب اللي ذكرناها. And the other mission that our goal we're trying to achieve balance is to achieve balance between maternal and the fetus hyperthyroidism. So we want both of them to be hyperthyroid, and all the obstetrician will come and say, okay, my concern is the pregnancy cause, the fetal well-being and fertility if the patient wishes to get pregnant, if she hasn't got pregnant as yet. So we have to collaborate our priorities together and put it in one basket. In preconception counseling, which what I had with this patient, هنا كان أكو خلاف ما بين the trajectory اللي بحاول أخليه إلها وبين المريض priority. المريض, she wants to get pregnant as soon as possible because she's 34. So there is a desired conception time by the patient, and there is the advice time for that safe time for conception that I'm advising her with. فأنا أقولها انتظري وهي تريد وقت مبكر. هاي مشكلة طبعا. We don't recommend conception unless the patient is biochemically and clinically hyperthyroid. Her TSH was still low. We like it to be normal in at least 2 different determinations. I have discussed with her the risk for her and the child and the fetus and the newly born child, and I took her through the risk and benefit of each treatment options we have. إذا اختارنا anti-thyroid drugs, then this need to have a very clear documented consultation. وإحنا ذكرنا بالمحاضرة أنه هناك دراسة أثبتت أن المريض can only take maximum 25% of the word you're giving in any consult, مو إلا علاقة بالثايرويد pregnancy ولا general or your endocrinologist specialty. Any specialties, حتى surgical consultation, المريض tend to gravitize only 25% or less than 25%. يعني 3/4 الكلام والنصائح تعطيه إياه ما راح يسجلها بشكل. لها سبب أنا دائما أسأل المريض، وهذا ذكرته بالمحاضرة، عيد علي اللي فهمته. Can you tell me, can you run by me what you've understood from my consultation? وعادة من يجي المريض يبدي يحكي يتكلم بثقافته بمستوى الصحة، بمستوى الثقافة الصحية اللي عنده، وهذا يختلف. المريض هو مو طبيب، وبالتالي قد يكون الوعي الصحي عنده شيء بسيط متواضع، وقد يكون شيء جيد، وقد يكون فيه أغلاط مفاهيم خاطئة كثيرة من الإنترنت والجوجل وما أعرف إيش. فدائما أنا أسأل المريض في حالات خاصة في الأمور المهمة، يعني من أكون عندي clinical twist وأنا أقرر فد شيء مهم جدا كأن يكون surgery أو planning surgery against medical therapy إلى آخره, which were I decided for this patient. يعني دائما أقول للمريض عيد علي إيش فهمت، اشرح لي شو فهمت من عندي. Okay. Now, moving along to preconception counseling, I did consider surgery, and I'll tell you why in a second. I did advise her if she were to get pregnant, she needs to start PTU immediately. فيما قد يكون هناك unplanned pregnancy، المريض يستعجل وتصير حامل بأسرع من الوقت. if you وأقول لها المريضة إذا if you missed period at any time، وهي كان عندها irregular periods بالمناسبة، then you need to check your HCG any time you miss a period. Now this is an elegant study that showed the percentage of patients who have their TRAb level normalized. Of course, they normalize quicker with medication and at higher percentage normalize with medication than with surgery. So the medication is a little bit more effective than surgery in normalizing the TRAb levels. عموما الsurgery radio ablation takes about 5 years to normalize. It's just hopeless. If anything, radiotherapy can promote antibody, and this is in the other study that showed that actually antibody titer goes up after radioablation, and at the start, because of the thyroiditis, which doesn't have to be clinical, so it can be subclinical or subtle thyroiditis after radioablation, and then start to come down gradually over 5 years period. ولكن surgery, if you look at it here on the dotted line, it actually took almost 1.5 years to normalize. So the TRAb level, even when you take the thyroid out, It doesn't get normalized overnight. You still need for more than a year to get it normal. Okay, now radioablation, فيما يخص radioablation and surgery and pre-pregnancy, there's always this issue of how long we have to wait after radiotherapy. So the guidelines suggest 6 to 12 months. Now the radiotherapy for Graves is different. وهذا سؤال انسأل وللأسف ما جاوبته بشكل واضح بالمحاضرة لأنه they collated the question how long after radiotherapy for Graves or thyroid cancer you can wait before advise the patient she's safe to get pregnant. Well, the answer is it's different categories. The radioablation dose in thyroid cancer is 10 times 10 أضعاف اللي نعطيه بالجريفز 150 millicurie against 15 millicurie. Okay. فبالتالي so that's one thing you have to bear in mind. So if someone had a thyroid cancer and removed in radioablation إلى آخره, I wait a good 6 months, if not 12 months. So that's one. But it's not an absolute contraindication for pregnancy حقيقة. Now we need to know that the half-life of radioiodine is about 12 days or thereabouts. So in 2 months' time, the vast majority of radioablation dose would be washed out. There's going to be a little bit lingering in the blood. Okay. Now, what we worry about is the impact of radiation, the iodine on the child's. On the fetus thyroid. Now the fetus thyroid doesn't get developed until 10 weeks. And what happens is when the fetal thyroid exposed to iodine, they don't have a check of the phenomena, the adaptive phenomena. So you end up with permanently hypothyroid during intrauterine life. Now you get 10 weeks window for the fetal thyroid to develop. Okay, and you've already had 2 months prior to that, so that's how many months? That's almost 4 or 5 months. So generally speaking, if someone had a small dose radiotherapy واللي هي نحن نستخدمها بالجريف disease مو بالثايرويد cancer, 15 millicurie, and they already missed 2 months, they already had 2 months after the radiation dose, and the patient is and she got pregnant, unplanned pregnancy. هذا هو السؤال اللي انطرح. Then then I can tell her, well, you can, if you أتكلم معها بطريقة وكأنه أقولها it's okay بطريقة غير مباشرة، على عكس لو كان هي مثلا ماخذة 150 مليكيوري لثايرويد كانسر راح أقوم وأتكلم معاها بحزم وبإصرار إنه لازم she has to terminate. Okay. لكن فيما يخص small dose of 15 millicurie, already 2 months, you're going to wait to have another 10 weeks, another 3 months for the thyroid, for the fetal thyroid to develop. The chances is very, very low. Okay, minuscule. All right. Now bear in mind احنا بنعطي راديو ابليشن، هذا اللي اقوله للمريض الحقيقه، هذا اللي هو النقطه اللي اقولها، مش الموضوع انه انت you have to be a thyroid before you get pregnant. مش الموضوع انه انت اخذتي 50 مليكيوري قبل شهرين، لا. You have to be a thyroid, that's one, and we don't know really if you need another dose of radioablation. 10% of radioablation is actually can end up with a failure. 10% of the patient will need to have another dose within 12 months, and we do wait for 12 months. So we really can't tell. And ناهيك عن إنه the TRAb levels tend to go up after radiotherapy, and that can have an impact on the child regardless of the mother thyroid status. مفهوم هذا؟ أتصور أتمنى يكون هذا الكلام واضح. Now, the issue, as mentioned, the loss of radiotherapy on the baby is the Wolff-Chaikoff adaptive mechanism is not developed till late pregnancy, so the child can end up with permanent hypothyroid. Now, radioiodine half-life is about 8 days, so 2 months you get most of the iodine washed out. Now, I'll move forward to another issue, the role of imaging. Thyroid ultrasound has a limited role. If you're suspecting thyroid nodule when you have T3 thyrotoxicosis without hyperemesis gravidarum and TRAB negative, that you could consider thyroid ultrasound. Unusual for a young population to have nodular goiter, but it still can happen. It's usual in the older population. But nevertheless, it can happen still. We still see it every now and then. Thyroid scintigraphy, technetium, pertechnetate, musciodine scintigraphy. After 16 weeks, and we prefer after 20 weeks, and all what we do is we ask the nuclear physician to use a small dose, and that can help us sometimes to differentiate between equivocal cases. Now, antithyroid drugs, I'll move to the other option of the treatment. It can has the generic side effect to the mother, pruritus, usually harmless, but it can have vasculitis, skin rash and polyarthritis and lupus and the rare agranulocytosis. There is also generic side effects of aplasia cutis and urinary and cardiovascular anomalies. The PTU, the PTU is the first drug of choice in the first trimester because it carries less teratogenicity than carbimazole. Why we continue on it? Because it has the potential for fulminant hepatic failure. It does cause hepatitic hepatitis, unlike carbimazole, which can cause congestive hepatitis. Now, the latter is reversible, while the former is not. So we do have certain cases when they were on a high dose of BTU for a long time who end up with liver transplant. Now, carbimazole has a more dreadful teratogenic effect than PTU. They both can be teratogenic, and it's all dose dependent. There is a report suggesting that 50 milligram or less of carbimazole during the first trimester shouldn't cause much teratogenicity, but the reality is there is still a chance, albeit minimized with lower dose of either carbimazole or PTU. There is this dreadful aplasia cutis, and there's a certain facial features with nasal bridge affected primarily, and as a distinctive phenotype that you get with carbimazole exposed fetuses. So these are permanent disfigures that we can avoid by switching over carbimazole altogether at any dose to PTU. Now, the study from Japan, it looked at 1,500 female in each arm, and the control was 2,000, that clearly showed that methimazole has twice as much teratogenicity than the PTU and the control. Now, this is the PTU on the green bar here. Now how about the FT4 target? Now, we don't have a proper validated FT4 for a pregnancy for trimester-specific reference range. However, this is a study that looked into the neonates that were born with a low FT4. The percentage of neonates, if the T4 of the mother T4 during pregnancy was the lower side of normal, lower 2/3, then it's about almost 100% of fetuses will be born with a low FT4. Often, إذا كان FT4 in the mother blood during treatment was low, under 9 or under 10, then under 10, then the percentage of the chance for the child the newly born child to have low T4 will be 100%. إذا كان mother's the maternal FT4 and the lower 2/3 of the normal reference range, the chances for her child to be born with low T4 will be 36%. Now, if the FT4 in the upper third of normal range, the chance will drop down to 10%, but not 0. And this is what we aim at when we treat someone with antithyroid drugs, pregnant female antithyroid drugs, we like the FT4 to be high normal or even slightly elevated. And I did الحقيقة ذكرتها بالمحاضرة. سألت Prof. Cooper, what if the T4 gone up a little bit above يعني 20, the upper normal range? That's harmless. Just like case of gestational hyperthyroidism, you can have an FT4 21, 22, 23, and it's harmless. So that's where we should, and that will help us to minimize the dose of the antithyroid drugs. Now, there is a chance of Graves to go into remission. We did tell that to the patient. So if the patient is only on one tablet, then we can withhold it in the second trimester and see how her TFTs behave. Now, the chances for the thyroid for Graves to relapse, for someone who already gone out of Graves in remission, she got pregnant after a year or two, if she had a suppressed TSH or tripositive, these are risk factors for relapse during the pregnancy or during postpartum puerperal period. If the patient was on a high dose of ATD prior to course termination, large goiter, and if someone had treatment under 6 months, of course they will have very high relapse rate. Now, this is a study that looked into the possible side effects, and I can tell you here that the cardiovascular, respiratory, and digestive system hazard ratio is a lot more of the percentage of patient affected is probably twice as much as the PTU. While the PTU is primarily affects the urinary system with hydronephrosis and so forth, and also it can affect the ears with a lot of canal fistulas. But either way, the message to take home from this is that both of them are teratogenic. However, the carbimazole is a bit more teratogenic than PTU. Now, went to time to switch in the study. They looked to the safe window, and you could see here the time to switch to PTU should be on week no later than week 5, and the time to switch back to carbimazole is as early as 10 weeks. Why week 5? Because it takes the women usually know they got pregnant after they miss a period, so that's 4 weeks. On week 5 they report to their doctor, they check their HCG positive, that's when they get told they're pregnant, and that's when they switch them over to PTU. Now, in the preconception clinic, we prefer to start PTU even before they get pregnant. So even preconception, starting PTU is fairly advisable. Now, in this study, they showed the hazard ratio for number of birth defects from using carbimazole during this teratogenic period is actually quite significant. Because there was a 20-day delay, so the cases they were switched over to PTU, there were median of 43 days, and they did show there's actually no birth defects at all. So like in the carbimazole median of 63 days, so it's 20 days delay in switching over from carbimazole to PTU has caused an excess of birth defects. So the message to get home to take from this slide is even 20 days delays can cause quite a bit of significant birth defects, and we prefer to switch over to PTU even before falling pregnant, and to switch back to carbimazole once the thyroid is about to be formed and once the organogenesis is established by 10 weeks. Okay, now the earlier the better, as I said. Now, when to consider surgery, and this is a question that we did not address properly الحقيقة بالمحاضرة. من يحتاج المريض, being on antithyroid drugs doesn't mean the case is over. Graves' disease can behave in a very aggressive way. Patient can develop side effects, allergic reaction, liver failure. Their eye condition might get worse because of the antibody titer is going up. and you might need to have high doses of ATDs. Once you reach that dose, then really it's about time to consider surgery. Okay, we like it to be a lot less than that, maybe 2 or 3 tablets, 4 tablets a day. That's we can put up with. But once they go to these phenomenal figures, then I mean, you still need them anyway to get the patient euthyroid before you take them to theater. But we don't like them to continue. We don't like to continue these through pregnancy. So the commonest cause I find الحقيقة for poor failure of anti-thyroid drugs is poor adherence. المريضة تتصور إنه هي إذا قاعدة تأخذ علاج ممكن يأثر على طفتها ويسبب تشوهات خلقية، فما تأخذه وتقول لك إذا صير خطر على حياتي يعني ما عندي مشكلة أموت يعني ولا طفل يتأذى وما إلى ذلك. So وهذا أيضا خطأ طبعا، لكن ممكن out of desperation they do that. But I actually find that in my experience this is the commonest cause of ATD failure during pregnancy. When to consider surgery, of course, in the second trimester, we do cover it with beta blockers. I still prefer propranolol لأنه short-acting beta blockers, and it's a time-tested drug. And we do give steroid cover around surgery لأنه احتمال يصير عندهم thyroid storm, and termination is a last resort. Okay, so surgery can be done quick. It can be very brief, half an hour or thereabout, under 1 hour from induction to recovery, and done by the endocrine expert surgeon uneventfully. Now, fetal hyperthyroidism, this is what we monitor when we give ATD, all right? Goiter can develop, but usually takes a few weeks to develop by the fetus. Tachycardia can be very early sign, and it's very reliable. Anything above 160 is a call for us to adjust, to titrate up the anti-ATD dose. They can have oligohydramnios, hydrops, growth restriction, and some bone ossifications and so forth. Now, how to treat the fetal hyperthyroidism? إذا كانت الأم hyperthyroid مثل ما قلنا بهذه الحالة, we treat both. We just increase the dose of the ATDs, all right? لكن إذا كانت الأم euthyroid with a past history of grave disease, that's when you need to block and replace, okay? This is the only condition that we block and replace. We stopped doing this approach in the non-pregnant females. And what do? We give PTU, 2 tablets, or carbimazole, 2 tablets, depends on the trimester, trying to bring the heart rate of the fetal heart rate down. And then, of course, the mother TSH will go up. Once the TSH goes above 4, that's when we need to give her thyroxine and bring the TSH down to the trimester-specific normal range. Please do remember that we do not block and replace in pregnancy unless and until we do chordocentesis and check the thyroid function. لأن التachycardia of the fetus could be non-specific طبعا, ممكن تكون لأسباب أخرى. So you need to have a biological evidence, a biochemical evidence عفوا, إنه the fetal is going through hyperthyroidism, and you could do that safely with the efficient ultrasound guided and efficient an expert obstetrician to do the chordocentesis. Now, again, this is in case when the mother is TSH receptor antibody positive, that crosses the placenta and causes the fetal hyperthyroidism, ولكن الأم is still euthyroid. Now, what happened in postpartum? Does we have a possible recurrence of Graves in the postpartum study? That's when you can do the scintigraphy and you can see that worsening eye signs, and you treat the person. If the mother, of course, is lactating, we prefer PTU, and usually we don't give more than 4 tablets, but we still can give carbimazole in lactating mothers. Class B drugs. So that's one. In case of thyroiditis, we do scintigraphy. This is the commonest scenario in postpartum hyperthyroidism. It tends to be very mild بالمناسبة. Postpartum hyperthyroidism مش بس ترانزيت تكون وإنما تكون أيضا mild وما تحتاج عادة إلى علاج. You do the scintigraphy and you can tell there is a reduced uptake there. This is a study that looked into the TSH profile according to the TPO antibody titer. So the higher the antibody titer in the blue lines, the more likely your TSH will not only drop down in phase 1, but it can go up into the hypothyroid state. Once they go up, they call it biphasic. Once they go up to the hypothyroid state, there is a chance, different reports give different chances. There's a chance for it to normalize, so that's phase 3, or remain permanently hypothyroid. At the end of the day, TPO antibody positive مثل ما شفنا بالحالة الأولى is positive in 10% of pregnant females, about 10%. It actually carries a risk of miscarriage even with normal TFTs. Half of the patient will, so half of these 10% will have a deranged TFTs postpartum, okay? And the minority of them will develop clinical disease, and hyperthyroid مثل ما قلت لحضراتكم is usually transient phase, and that's with a higher TPO antibody type, you're more likely to get a more profound clinical disease. There is the patient, the advisor, I tell the patient after everything is sorted and normalized, you will have, okay, next pregnancy you will be at risk of developing the same problem, and you will have a lifelong risk of becoming permanently hypothyroid. You do need to check your thyroid levels lifelong, perhaps once a year, unless you develop symptoms. ونعلم المريضة شنو symptoms of hypothyroidism. If you develop symptoms suggestive of hypothyroidism, you need to check your thyroid, your TSH, earlier than your scheduled annual appointment. Now, what happened to the newly born child? مثل ما قلنا لحضراتكم, the neonatal thyroidism related to the transplacental streaming of the TSH receptor antibodies. About 5% of the patient with Graves will have the TRAPS causing clinical neonatal thyroid disease, and usually associated with high TRAPS level, okay, much mildly elevated. Now, there is the phase of hyperthyroidism related to TRAPS. There is also a phase of hypothyroidism. So بعد ما يكون يعني هناك 3 سيناريوهات الحقيقة. التراب موجودة بالطفل والمريضة ما كان ماخذة ATD، فهذا في الطفل من أول يوم يصير عنده hyperthyroidism. لكن إذا المريضة ماخذة ATD, it takes about a day or two for the ATD to be to be half-life معناتها 1 day, 1 or 2 days or 3 days to be washed out، وتبقى التراب unopposed in the newly born child، ويصير عند الهايبرثايرويدزم بعد حوالي أسبوع تبدي عند الهايبرثايرويد. التراب ما تختفي، ممكن تبقى بالجسم لمدة سنة، وخلال هاي السنة الطفل TFTs need to be monitored for a whole year. Now, the other important thing is if the patient has a hypo after يعني إذا كان التراب will be washed out, will fetus or the neonate had a persistently low TSH receptor, so they will end up with a phase when they become centrally hypothyroid, and it takes a while for the TSH to the pituitary to pick up. يعني حتى الطفل ممكن يحتاج ل thyroxine replacement for a short period of time, for a few months, until the pituitary picks up in order to stimulate the thyroid to secrete hormones. So that there are 3 different scenarios in the newly born child, and at the end of the day, you do need to monitor the TFTs of the newly born child of a mother who has TRAP positive, regardless إذا كان عندها hyperthyroidism or euthyroidism during pregnancy. You do need to monitor the TSH receptors and the TFTs in the newly born, in the child, in the neonate for the first 12 months at least. I'll stop with this slide, and I look forward to seeing you in the first Friday of November with our next grand round.